Good evening, everyone. How are you all? I'm good. Thank you all. So again, welcome to First Aid AMC MCQ. I am Dr. Arshan. I'll be the coordinator of your 5 months AMC MCQ course. So all of you know that tonight is our first class of the free 2-week session. And I hope that you enjoyed our previous 2 classes that we have taken. Now, all of you know that this is the most awaited 5 months MCQ course that most of you are waiting for to start. Now, we run the course every 5 months in a year. So most of the time it comes like a two course in a year. And we really do a hard work in this two course in a year time. And as you can see that a lot of candidates passing from our course just because of this hard work. Now, AMC MCQ is the first thing in your journey to become a doctor in Australia, right? And many of you has heard that nowadays getting a job after passing MCQ is a lot better than what it was before. And if you are in like somewhere in, not in Australia, like any of the other countries, and you have a proper recency, the chances of getting a job just after passing MCQ is really good now. So don't take the opportunity now, pass the MCQ as soon as you can. That should be your motto. Now, the next question might be like, how long I should take the preparation for AMC MCQ? In my experience for the last 4 to 5 years, I would say that for MCQ, you will need around 6 to 8 month preparation, because most of you are working at the same time when you are preparing for MCQ. You have work commitment, you have commitments in your life, you have family. So all of this together, you will never ever be able to just read 12 to 14 hours a day and then be just done with the exam. It's very unlikely you will have that opportunity. Most of you will be working, will have a lot of commitment going on. And in between all of those, you have to also do your study and pass this exam. So keep it in your head that you will need around 6 to 8 months to appear the exam. And most of you will pass in the first attempt. And that should be actually, you can't think about passing MCQ in second or third attempt. That's so unlucky for anyone, I would say. So because it's the easiest one to pass out of all the exam in AMC you are going to give. Like AMC clinical will be a hard one to pass, obviously, because it's how it is always. The last exam is always the hardest one, right? So, but your first one, which is MCQ, it's not super impossible. It is possible, and most of you will pass it in the first attempt. Now, the important thing is to get a good idea about the exam, get a good guideline about the exam, and having someone with you who also going through the same stuff, just similar like you. That means you should have some steady buddy or a steady partner also. There is no other alternative to have a study partner for preparing your AMC MCQ as well as clinical exam. So the study partner helps you not only with your preparation, but also helps you with understanding what you are going through, because it's the same thing like you. The other person also will have a lot of commitments, and they're going to they're going to come to a meeting to discuss some of the questions with you. And that's how you will end up being a very good friend also. So a lot of candidates got their lifetime friends from this course, which we have been running for the last 5 years. So this is how you should also get prepared. Now, tonight's session is our first session on the 2 weeks free session, as you know. And many of you in here, I can see that you already joined the course, but this classes at the moment, this is a part of your course. It will not be repeated. So think it as your as the classes which we are going to do in your course as well. So, and why I'm doing that is that you need to understand how we take classes. Now, as I say initially, that anyone can take a very good class, and then you might feel, well, like this is the course I want to enroll. But maybe when you get their second, third class, or maybe after 1 month, you end up in a course which you are not enjoying yourself. And that's the reason we always provide this 2 weeks free session so that you understand where you are enrolling actually. And also you get to know our style, you get to know how we take classes and how this course is going to help you. And that's very important actually. And there will be a formal orientation class with the course student just after this free 2 week session is over. Now, you know that the classes are usually given in your software. So some of you might already got the access who enroll for the course, some of you not. Now, when you get enroll yourself in the course, you will get access to our software and you will get all the course materials over there. For the time being, we are also giving the recording of the class in your Facebook and also our YouTube. So you can get the recordings for the initial 2 weeks in the Facebook group also. But after free 2 week session, all the course materials and everything, you will get it in the software. Okay, so let's move on to cardiology session. I can see that many of you are in it also. So if you guys have any questions, anything that you want to know, just write it in the comment section and I can always answer it over there. Okay, before we start, let's just go through a little bit of video about the cardiovascular system, and then we will start.
The normal heart has two sides, a right side and a left side, and four chambers, the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
So that's how actually your heart works, right? In just 1 minute, you just learned that how your heart physiology works. Sorry guys, what's happening with the syncing? The class has started. Facebook, I can see that they can hear me properly. So what's happening? Any trouble with hearing, guys? Who can't see properly? Dr. Nahrin? Is there anyone who can't see the lectures or anything? It should be fine actually, because we are taking the classes similarly like this for a long time. If someone is not able to see, just make sure that your internet connection is working properly. I think like maybe somehow your internet connection is not working properly. That's why you are not able to see or hear. All right. Now, before we move into cardiology, first thing that you need to learn that how you can learn what are the resources that you need for your cardiology preparation. Now, tonight I'm going to be super slow just because you need to get into my style and you need to get adapted with me. And once you get adapted with my thing, and then you will understand everything more clearly and I will be more faster. Now, when we do cardiology, it means that this is a theory class that we are doing tonight. The classes are divided in a way so that you get theory knowledge and you work on that theory knowledge to solve questions. So tonight and also the next class, we are going to do theory session only on cardiology. And after the theory sessions, then we are going to use this theory knowledge on solving some cardiology related question. That's your cardiology question solve class that's coming up. You can see it in your Facebook schedule also, that when is your cardiology question solved. And there are also some classes which is a random question solvation class. So it's a monthly update of new questions, so like a sample questions that we solve with you so that you get to understand those questions and topics. And there is also similar class like that in your free session that's coming up. I think it's mostly on 17th February, most likely. So if you just open up in your Facebook, you will be able to get the schedule. So these are the classes. Classes are divided into theory class, and then we do subjective question solvation based on the theory that we are learning. And there are also some just sample question solvation with a monthly update. And we also do it every week. So in every week, you get 3 classes. 2 classes are mainly on theory. Sometimes also we do question solvations on theory class. And one class every week is just on random question solvation with a monthly update. So that's the classes. Now tonight is about theory, right? So we are doing cardiology as our theory tonight. And for cardiology, what are the resources that you guys need to follow? Now, this has been changed. So JM 8th edition will be our main focus. Now, still we haven't got the 8th edition PDF version. Most likely we'll be able to get it in a month time or maybe in few weeks time. So JM 8th edition will be our focus of MCQ preparation. In JM 8th edition, these are the chapters that you guys need to follow for your MCQ preparation of cardiology. So chapter 40, chapter 70, 85, 86, 87, 88, all are cardiology related chapters. And we're going to discuss this thing with you. In case of MCQ preparation, we always try to learn a little bit about the Kaplan step to CK. So if you have heard about USMLE preparation, in USMLE, there is a book which we call Kaplan Step to CK. And Kaplan Step to CK has all the important subjects that you need for your MCQ preparation. Now, a lot of difference are there in terms of guideline, which we will go through you. Okay, but Kaplan Step to CK has a very good explanation of most of the important topics, and we will also use this one as a part of the preparation. For your medicine website, we will take help from some of the Google websites, which is mainly Australian website. For any kind of medicine related topics, you always should go through RACGP guideline. And RACGP guideline is the Australian guideline, so we always follow this one for any medicine related topics. Sometimes if you want to learn a little bit more and in depth, you can also go through the Medscape or e-medicine guideline. And also to get a concise idea about a topic, you can also go through MedBullets. These are all websites that is very helpful to get an idea about particular topic. Like you want to know about constrictive pericarditis. you want to know about pericardial tamponade. So JM does not have too much about this thing. So from where you can learn those? From this website. So you just write in Google that pericardial tamponade RACGP guideline, and that will come up. Okay, or you want to find out a little bit like a very concise explanation of pericardial tamponade, you just write pericardial tamponade med bullets. You will end up getting something in the med bullet. Then we also will provide you QBank on which you can go through the questions related to cardiology and try to just read the explanation and solve those questions, which will give you a good idea. But never ever just start with QBank. You should always start with theory, reading these books first, and then when you have an idea about the topics, then you only open the QBank and try to solve the questions. And obviously, you will take help from our lecture note as well. And there will be also a cardiology question solve file, which will contain more than 100 questions related with cardiology, and that we will solve with you as well. So as a whole, you will end up getting a very, very good idea about these theory topics, and you will also get to know how to solve questions. Once you are done with this thing, then you will go into the software. In the software, you will get our mock test on cardiology. And then you just open that cardiology mock test from the software, and you try to use the time-based software mock test, see that how well you are prepared on this particular topic. And that is exactly how you should prepare yourself. You start with one topic, like one subject, like cardiology, respiratory system, GIT, and you just follow the similar approach for every topic. And there will be nothing left if you just do in that way. There is nothing to get confused about. Now, that doesn't mean like having all these resources does not mean you have to go through each and everything, right? It's only when needed. Most of the time, if you just follow our lecture note and also the JM, that's all that you will need. But time to time, there will be some topic which is not in JM at all. Then we will go for RACGP guideline. We might go for med bullets, especially when we are trying to solve some questions, which is very confusing. Then we will go through these resources. So there is nothing to get scared about too many resources or too many sources. Okay. Now, AMC does not have only one particular guideline. You have to learn in your own way. You can't ask AMC that give me only one guideline and I will just read that book and I'm done with the thing. No, it's the international exam, guys. You have to learn those things from these resources, get your knowledge up, and then you can use your knowledge to solve questions and to solve those MCQ in your exam. But if you ask me which one is the most important resource to follow, that's your JM. And these are just kind of additional one from where we can learn some things if needed. Okay, so let's start with chest pain. Now, before that, let me show you from the JM. So always in your laptop. Now remember one thing. I know many of you are not very comfortable with reading from computer or laptop. But now that this is an era of technology, you can't just rely on book-based reading. It has to be changed because in AMC, you will end up reading a lot from a lot of websites. Trust me, that will be. Now you might be thinking, no, I will just read one book. No, it will never ever be like that. You have to go through a lot of websites eventually. So start using laptop and start reading from the PDF, because then you can open a lot of books at the same time And if needed, you can just highlight those things. You can write anything important that you want. So it becomes so easy if you are just following through a PDF version. But for JM and AMC MCQ handbook, you can read the book version because that becomes easier for me also. So that's all right. But for other things, you should always read it from the website, from your laptop. Now, tonight we are going to go for some of the chapters related with cardiology, right? So we'll start with the chest pain chapters. So chapter 40 is your chest pain chapter in your JM. And also, if you just go through all the chapters that I have mentioned earlier, these are the chapters that is important for cardiology that we are going to go through. The most important one is chest pain for your cardiology preparation. And let's start with that now. When a person comes to you with a chest pain, it's not just heart which might be involved. A lot of things can be involved in the same way, right? So what are the differential diagnosis of chest pain? Chest pain can be related with cardiac causes. The most important to rule out is myocardial infarction or ischemic heart disease or angina pectoris. Chest pain can be due to pericarditis also. We'll discuss each and everything. Let's just go through the topics first. Vascular cause like aortic dissection can be a cause of chest pain. Then you have some respiratory causes. These are the most important respiratory causes of chest pain. So pulmonary embolism, pneumonia, pneumothorax, and any pulmonary neoplasm or cancer. These three are the most important. GIT related, especially if you have got a esophageal reflux or esophagitis, if you got peptic ulcer disease, that can cause chest pain. Musculoskeletal is also important, especially if you have got a costochondritis or TJ syndrome. If you have got a fractured rib, that can give chest pain. There are also neurological causes like herpes zoster that can also give chest pain. So these are the most important causes of chest pain. If you get a patient with chest pain, you think about, is it a cardiac chest pain? Is it a respiratory related chest pain? Or is it a kind of vascular like aortic dissection? Is it GIT related or is it musculoskeletal related? So that's how you think in your head. Now let's discuss about characteristics of this chest pain. Sometimes even by looking at the character of the pain, you will understand that what is the cause of this chest pain. Now in the lecture note, it is a collection of all the important things from JM. Some things are from Kaplan Step 2, some of them are from various websites. Okay, so it's a combination. It's not only from JM. When you get a patient with acute coronary syndrome, which include your stable angina, unstable angina, myocardial infarction, the chest pain quality is kind of chest tightness, chest heaviness, or maybe someone is giving pressure on the chest. Along with that, patient also complains nausea, vomiting, and sweating. So that's how the chest pain related with your cardiovascular, like myocardial infarction or acute coronary syndrome chest pain feels like. If it's a sharp knife-like stabbing pain, which get worse with taking deep breathing or coughing, that suggests pericarditis. So sharp knife-like stabbing pain, which gets worse with taking respiration, coughing, or deep breathing, that's pericarditis, chest pain. If a patient chest pain is responsive to nitroglycerin, that's most likely it's either a ischemic heart disease or is it a esophageal spasm. If chest pain gets worse with nitroglycerin, that suggests gastroesophageal reflux disease. So these are very, very important clue for your exam, guys. A little bit of clue will be always given in the exam, If you know this thing, you will easily pick up the clues. And there are also some of the signs that will help you to diagnose a condition, especially if you take blood pressure and you have got a difference of more than 20 millimeter systolic blood pressure in both arms. Like in the right arm, the systolic blood pressure is 120, whereas in the left arm, systolic blood pressure is 100. So when you get a more than equal 20 millimeter difference of systolic blood pressure in the arm, that suggests aortic dissection. So very important. This could be just the only one clue in the exam. And if you know this information, you will be able to diagnose it. If there is a fever with chest pain, think about something infection. So which infection can cause chest pain? Most likely pneumonia, could be mediastinitis. Sometimes even a patient with pericarditis can get a little bit of fever. But if fever, cough, shortness of breath, and chest pain is there, these are the four triad or four symptoms of having pneumonia. And there are also some murmur which will help you to diagnose some of these stuffs. Like let's say, if you got a patient with a new left bundle branch block with a chest pain, that always suggests acute coronary syndrome, or most likely this patient having a anterior or lateral infarction. If you get a patient with a new fourth heart sound, that also suggests angina or infarction. If you get a S3, that means the third heart sound, which is called gallop rhythm, that suggests heart failure. And there are lots of murmur that we will discuss in various valvular heart disease later on. If you get a patient that having bibasilar crepitation in their lungs, that suggests, again, CCF or acute pulmonary edema. So these are all important signs that will lead you to diagnose various causes of chest pain. So now we know some of the symptoms. Now we know some of the signs of cardiovascular system. We are not still into the specific topic. It's just the introduction, guys. Okay. Any patient coming to you with chest pain or epigastric pain in middle-aged or elderly patient, you should always do ECG. Your initial investigation should be always ECG. Now, when I said initial, you should also understand in the exam, they use some particular word to ask a particular question. Like, let's say they have given you a chest pain patient, and they are asking you, what is your next most appropriate investigation for this patient? Whenever they use the term next, it means initial. What is your initial test for a patient who is having chest pain? ECG, always. There is nothing that you should think apart from ECG with a chest pain patient. Now, sometimes they would ask you, what is the most appropriate investigation for this patient? When they ask only most appropriate, that means they're asking you the confirmatory investigation. They're not asking you the initial investigation. So if you get a patient who is having all the symptoms related with acute MI, what is the confirmatory investigation? You should do a troponin, right? If troponin goes up, then you can say, yes, most likely this patient having a MI. So that you need to also understand what actually they are asking. If they're asking you, what is your initial investigation? That's initial test. If they're asking you, what is the confirmatory investigation, then you have to choose the best investigation to diagnose that condition. So we'll go through those terms again and again throughout our course, that what exactly it means. Now, most of the patient with a myocardial infarction will have an abnormal initial ECG. Some patient might have a normal ECG also, but they might have AMI. So that's why having AMI can be quite confusing sometimes, because you do an ECG, but ECG is totally normal. But when you do troponin, you find out troponin is sky high. That patient is having non-ST elevated AMI. And if someone having ECG changes with AMI, that suggests that they're having ST elevation in their ECG. So now you know AMI has two subtypes, ST elevated AMI and non-ST elevated AMI. When we discuss the ECG, you will understand it a lot, like what is ST elevation, what is pathological Q wave, all these things we will discuss one by one. So first you have done ECG. You haven't got any changes, but the chest pain is typical of AMI, like chest pain, which is in the left side, feel like someone is pressuring on the chest, but the pain is radiating to the left arm, neck, and jaw. All right. And the pain is persistent for more than 20 minutes. And you have given nitroglycerin, but still patient is not getting like it is, the chest pain is still not getting better. All of this suggests that it's a possible acute myocardial infarction. You have done a ECG, ECG is normal. What is your next test? Guys? Cardiac enzyme, but what is the best cardiac enzyme that we do? We do troponin, not CKMB, we do troponin. There is CKMB nowadays, we will not even think about CKMB unless it is really needed. So troponin is your next test. If troponin is high, you can say this patient having myocardial infarction, but the term that you will use, that is called non-ST elevated MI, or you can also say subendocardial myocardial infarction. Now, apart from cardiac troponin, sometimes there are also some other cardiac enzyme like CKMB. CKMB is cardiac specific, and yes, it can be useful for early diagnosis of MI, but we don't do that because troponin is the best one. Now, when you do a CKMB, if it is a MI patient, it starts to get detectable in the blood 4 to 6 hours after the chest pain and get picked up in 12 to 24 hours, and it get normal in 2 to 3 days. Whereas cardiac troponin, usually it will get elevated at the same time like your CKMB, but it will persist for a longer period of. So if you see that CKMB, you get it in the blood elevated by 4 to 6 hours, and it will get normal in 2 days' time. Whereas troponin, it will be present in the blood from 4 to 6 hours, but it will get normal in 1 to 2 weeks' time. So that's why it is a good one, because even if the patient present to you later on, you can also know that this patient had a MI, maybe 2 or 3 days back. Now the question comes, you have got a patient with chest pain, you have done ECG, ECG is normal, and then you have done troponin, and troponin came up high. You diagnose the patient with MI. Okay, and maybe you also treated the patient for the MI. But just after 5 days, patient again started to have chest pain. Now, if you really want to know that if this patient having a chest pain related to the old MI or there is a new myocardial infarction, what test you have to do? This is the time you do the CKMB. That's very good. Because in the CKMB, CKMB should get better in 1 to 2 days time, right? Now, if you do CKMB after 5 days and it's elevated, that means that this is a new MI. Okay, and you can't rely on troponin at that time because this raised troponin that you are getting after 5 days, it might be related with the old MI. So this is the only time this CKMB usually helps. Otherwise, we don't need to do CKMB to diagnose myocardial infarction. Troponin is the best one. So this is the line that I want to focus. The cardiac troponins may remain elevated up to 2 weeks after onset of symptom, which makes them useful as late markers of recent acute MI. So if you want to diagnose someone with a recent acute MI and patient present to you late, then you have to do a cardiac troponin. Even after 1 week, you might get it elevated. Now, is there any role of cardiac troponin to give you the prognosis of this MI? Like, if the level is high, does it have any relationship with the prognosis? Yes, because if you get as high the serum troponin level gets, the prognosis is that worse. Okay, so if you get a patient whose cardiac troponin is sky high, chances of dying from heart attack is lot high in that patient. Now let's say you have got a patient with a typical chest pain of MI, and that chest pain started 30 minutes ago. And you have done cardiac troponin that time that came as normal. What do you do next? Do you just discharge the patient because normal troponin also normal? No, you can't, because this is just 30 minutes, because the troponin will get into the blood in 4 to 6 hours time. So you need to repeat the ECG as well as troponin in 4 to 6 hours time. So usually every 2 hours, you repeat the ECG first, and then you repeat the troponin. Okay, so both ECG and troponin should be repeated because there will be changes in the ECG also. So question comes in this way. You have got a patient with a chest pain, typical chest pain of MI. You have done ECG and the patient presented to you 30 minutes, after 30 minutes of chest pain. You have done ECG normal, troponin normal. What do you do next? And they have given you option that discharge the patient or send the patient to the GP. And sometimes they say repeat ECG in 2 hours, repeat troponin in 2 hours. Now, between repeat ECG and repeat troponin, which one you will do next? That's the confusion comes. You have to do the ECG first, followed by troponin. All good? So a lot of questions I am also discussing with you along the theory so that you understand how this theory is actually helpful for solving the questions. Now, sometimes we may need to do X-ray, like a chest X-ray, to rule out some other causes of chest pain, like pneumonia, pulmonary embolism, not pulmonary embolism, pneumothorax. So those will be helpful to get diagnosed with a chest X-ray. These are some of the signs or symptoms of various chest pain. If you get a patient with aortic dissection, the type of the pain is very typical. It's a sudden onset of severe, sharp, tearing chest pain that radiates to the back. So if you get a patient who is having a central chest pain, sudden onset, extremely severe, kind of tearing chest pain, which radiates to the back, that suggests aortic dissection. If you do a chest X-ray, you will get widening of the mediastinum. And if you want to confirm the diagnosis of aortic dissection, you have to do a transesophageal echocardiogram. We will go through the detail of it, okay? But let's just start one by one. Pulmonary embolism, we will discuss in our respiratory system. Pericarditis, the pain you already know. Pericarditis pain is a kind of sharp, knife-like stabbing chest pain. The pain usually gets relieved by leaning forward, but get worse with lying down. And also it gets worse with taking a deep breathing or also with coughing. Most of the time, you will get a history of recent viral flu-like illness before this chest pain started. That's a very important clue. On auscultation of the heart, you might also get a pericardial rub. And if you do a ECG, you will get diffuse ST elevation without any Q wave. And all the troponin, CKMB, everything will be normal. We'll discuss the ECG of pericarditis during the ECG class. And these are actually from your Kaplan step 2. See that some of the other causes of chest pain, the characteristic has been discussed in here. So costochondritis, if you get in the question, the patient having a chest pain, and if you palpate the chest, it is sore to touch. So chest pain, which you can reproduce by tenderness, and if patient says my chest is sore to touch, that always suggests costochondritis. Someone's microphone is on. Okay. Reflux, it's not very important. Peptic ulcer, there will be kind of epigastric pain, which will get worse after eating. Okay. Now, always remember, any middle-aged or elderly patient having epigastric pain, you should consider ischemic heart disease as one of your DD. You should do a ECG always. Myocardial infarction, we already know the pain usually lasts more than 15 minutes, not 20, I would say more than 15 minutes. And we will discuss about aortic stenosis. We know about pericarditis. We know about dissection of the aorta. Now, let's move on to the most important topic, which is your ischemic heart disease. Ischemic heart disease, it's a whole lot of discussion. What is ischemic heart disease basically? It means that the coronary artery, which is supplying your heart, it's not getting enough blood supply. Some of them are just a little bit of blockage, like this one, which is, you can see this is the lumen of the coronary blood pipe or coronary artery, and a little bit of blockage by atherosclerotic plaque are there. And this patient is actually a patient with stable angina. So in a stable angina patient only get chest pain typical of ischemic heart disease only when they are doing exercise or any kind of exertion. And that chest pain usually gets better after taking rest or after taking nitroglycerin. So stable angina means that you are not getting a full blockage of coronary artery, just a little bit of blockage. And time to time, if it is not well treated or the risk factors are not well managed, then this atherosclerotic plaque will gradually become bigger and bigger, and eventually it will end up causing a full blockage of that coronary artery, when you will call it as a myocardial infarction. In case of stable angina, patient only get pain during exertion and it gets better with taking rest. Now, some of the other kind of chest pain, like unstable angina, the chest pain will be more than 15 minutes in duration. Sometimes even after taking rest, patient will not feel better. Sometimes even nitroglycerin will not relieve the chest pain. So unstable angina, that's also little bit of like you can say that atherosclerotic plaque are going to totally obstruct the coronary artery. And then there is non-ST segment elevated MI or subendocardial MI. And then there is ST segment elevated MI. These are the three most important conditions which we keep under acute coronary syndrome. Okay. Acute coronary syndrome is important because sometimes if you don't treat the patient, an unstable angina patient can end up having a non-ST segment elevated MI. A non-ST segment elevated MI can end up having a full-blown ST segment elevated MI. So we need to find out as soon as possible, and we need to start treating this patient. Now, before we go into a little bit more detail about this acute coronary syndrome, let's talk about some risk factor which comes in exam frequently. Now, the question comes, what is the single most important risk factor of having ischemic heart disease? So three things you should remember. If the question asks the single most important subfactor or what is the single most important risk factor of having an ischemic heart disease, that should be hypercholesterolemia or dyslipidemia. And among the cholesterol, if you are getting a high LDL cholesterol, that's the highest risk factor. Two other questions come. One is, what is the worst risk factor? So someone who got a coronary artery syndrome, and if they're having diabetes, that patient has the worst prognosis. So they ask you, which one is the worst risk factor for a patient with ischemic heart disease or acute coronary syndrome? That's diabetes. If they ask, what is the most common risk? Most common risk is hypertension. So you need to first remember these three important type of question. If they ask single most important risk factor, that's hypercholesterolemia. If they ask most common risk factor, that's hypertension. If they ask what is the worst risk factor, that's diabetes. Okay, so very important to remember it. Now, look at one of the questions. A 48-year-old woman comes to the office with chest pain that has been occurring over the last several weeks. The pain is not reliably related to exertion. Remember one thing, if a chest pain is not related with exertion, that chest pain is most likely not a cardiac chest pain, because cardiac chest pain is usually associated with exertion or exercise. She is comfortable now. Location is retrosternal. Pain sometimes associated with nausea. There is no shortness of breath. Pain does not radiate beyond the chest. What is the most likely diagnosis? So you have got unstable angina, pericarditis, pneumothorax, Prinzmetal angina, and gastroesophageal reflux. Always remember, before menopause, having ischemic heart disease in a woman is very uncommon, because the estrogen usually helps them to prevent this acute coronary syndrome. But after menopause, yes, their risk is high. And most importantly, when there is no relationship with exertion, you can easily rule out unstable angina. Pericarditis, you know the characteristic of the chest pain. So this pain is not characteristic. Pneumothorax patient will have shortness of breath most of the time. This patient does not have it. Prinzmetal angina, never choose this one unless you're really sure about the diagnosis, because we don't assume Prinzmetal angina as a first diagnosis of any chest pain. When there is no other causes found, then we think about Prinzmetal angina, which is mainly related with coronary vasospasm. That means the vessel itself does not have any atherosclerotic plaque, but in relationship to some emotion, some stress, sometimes the coronary artery can get constricted or vasospasm. And then because the artery is narrowed, the patient is not getting enough blood supply, and then they can get chest pain. But Prinzmetal angina, we always keep it as our last diagnosis. So your most likely diagnosis will be gastroesophageal reflux disease. See this one, menstruating women virtually never have myocardial infarction. So very unlikely. So which one of the following is the most dangerous to a patient in terms of risk of coronary artery disease? Not very important for your exam, but always remember having elevated LDL has the most dangerous in terms of risk of CAD or coronary artery disease. Now, there is a new disease which causes chest pain also. We'll just go through it very quickly. The condition is known as Takotsubo cardiomyopathy. Never ever seen in any exam, but you should know it. So a postmenopausal woman develops chest pain immediately on hearing the news of her son's death. She develops acute chest pain, dyspnea, ST segment elevation in lead V2 to V4. There is elevated level of troponin. Now, if you get this kind of feature, you should always think that this is an acute myocardial infarction. So once you know that a patient has got ST elevation, patient has also got elevated troponin, you diagnose the patient with acute MI, and then you send the patient for a coronary angiography. What is coronary angiography? In angiography, they insert a dye. That dye goes into your coronary artery and find out the level of obstruction or stenosis. Now, coronary angiography is normal, including an absence of vasospasm. If coronary angiography is normal, why there is ST elevation? Why there is raised troponin? That's very confusing, right? So this is the case with Takotsubo cardiomyopathy, where coronary angiogram will not find any atherosclerotic plaque or stenosis. You will also not find any vasospasm, which rules out Prinzmetal angina. And then if you do an echocardiogram, you might find out the left ventricular wall ballooning. This left ventricular wall ballooning that suggests Takotsubo cardiomyopathy. So it's an acute myocardial damage, most commonly occurs in postmenopausal women immediately following an overwhelming, emotionally stressful event like this case. And sometimes that leads to ballooning and left ventricular dyskinesis. So left ventricle does not move like as it is. As with ischemic disease, manage this patient with beta blocker and ACE inhibitor. Because this patient does not have any block, you can't do any coronary revascularization. Okay. Now that you know a little bit about this acute coronary syndrome, so let's go into detail. Acute coronary syndrome patient, you have done an electrocardiogram or ECG, and if you get ST segment elevation, you immediately call it as MI. You don't need to even rely on troponin to diagnose it. Okay. Now, no ST elevation. If there is no ST elevation and patient having chest pain, there is two possibilities, right? One, it could be unstable angina, or it could be a non-ST elevated MI. How you can differentiate between these two? By doing the troponin. If the troponin comes positive, that's non-ST segment elevated MI. If troponin is negative, that's unstable angina. So that's why troponin is really important for someone who has no ECG changes, but having a typical chest pain of acute coronary syndrome. Is this something which you guys are understanding? Any question? Good. So therefore, in establishing the diagnosis of non-ST elevated MI, cardiac troponin should be used to distinguish this entity from the unstable angina. Now, it is very important to know what type of acute coronary syndrome your patient has got, because the management is different. Why management is different? Like if a patient has got ST segment elevation or ST elevated MI, that patient has got full blockage of the coronary artery. And that patient needs thrombolytic therapy. Either you give it through medication like streptokinase, alteplase, any of those things, or you go for PCI, percutaneous coronary artery intervention. So thrombolytic therapy is important for patient with ST elevated MI, but it is not effective or needed in a patient with unstable angina or non-ST elevated MI. So not everyone will end up having a thrombolytic therapy or PCI. Only the patient with ST elevated MI usually will end up having a thrombolytic therapy. Now, what are the characteristics of ischemic chest pain? All right, I have got a few questions from you guys. So how we are going to diagnose unstable angina due to just pain? Yes, you have got a typical chest pain of ischemic chest pain, and then you have done a ECG, which is normal. You have done a troponin, that's also normal. That means the pain was due to unstable angina. We would not say more than 20 minutes, sometimes even more than 10 minutes can be unstable angina. You should keep it as a 10 minute. No, it will not be responsive to nitroglycerin in unstable angina. In unstable angina, sometimes a little bit of, like patient might feel little better, but not fully better. Okay, good. Now, what are the characteristics of ischemic chest pain? Stable angina, the chest pain duration is usually less than 10 minutes. Acute coronary syndrome, more than 10 minutes. Provoking factor is most of the time physical activity, exercise, or any kind of exertion or stress. Along with that chest pain, which is kind of squeezing, tightness, heaviness, pressure, the chest pain will also radiate to the neck, left arm, and jaw. Okay, so the characteristic of the chest pain is very important to understand. The location of the pain can be substernal, can be also left side of the chest. Associated symptoms, along with the chest pain, patient also gets nausea, sweaty, sometimes even dizziness, and shortness of breath. Now, have a look into the other causes. If a patient with chest pain has chest wall tenderness, most likely that's costochondritis, as we discussed. The chest pain which radiates to the back and patient having unequal blood pressure in between two arms, aortic dissection. Pain that get worse with lying flat and better when leaning forward, pericarditis. Pain in the epigastric region and sometimes get better with eating or sometimes get worse with eating, that's peptic ulcer disease. Having fever, cough, shortness of breath, that's pneumonia. Sudden onset of shortness of breath, having hypoxia or decreased oxygen saturation, that's pulmonary embolism. Okay, so we'll discuss the lung causes later on. Now moving into the ischemic chest pain a little bit more detail. Let's say you have got a patient with a stable angina. Will you just stop there? No. You should also find out that how severe is the condition of this patient. The first step, because in case of a stable angina patient, there will be no ECG changes. So, because you are doing the ECG during resting period, so you can actually provoke ischemic changes in their ECG if you can do a test when patient is doing a stress. And that is what we call as a stress ECG or exercise tolerance test. So if you have got a patient who gets chest pain on exertion and you did a ECG which came normal, you can send the patient for a exercise tolerance test or a stress test to find out that if there is any ECG changes when the patient is doing exertion. Okay. Now, exercise tolerance test, there is two things which is important. One, patient should be able to exercise. Like if a patient having severe joint pain in the knee joint or ankle joint, that patient will not be able to do exercise or run on the treadmill. So for them, you can't do this test. You have to do something alternative. Okay. And also you need to find out that the patient having a baseline normal ECG. So to do a exercise or a stress tolerance test, two things needed to be done. One, patient having a normal baseline ECG and patient is able to exercise. Now let's say, what if you can't read the ECG because there is some baseline ECG abnormality? If patient already having a baseline ECG abnormality like left bundle branch block, ventricular hypertrophy, patient is already having a pacemaker, okay? If that is the case, then you can't do the exercise tolerance test, but you have some other option. So those options, one of them is called nuclear isotope uptake. Nuclear isotope uptake, that's also known as myocardial perfusion scan. That's very commonly we do in Australia. Or sometimes you can do an echocardiogram to detect any regional wall motion abnormalities. So RWMA. So these are the two other things that you can do if a patient having a baseline ECG abnormality. How this nuclear isotope scan helps? Now, a normal myocardium will pick up nuclear isotopes such as thallium in the same way that potassium is picked up by the sodium-potassium ATPase. Don't even think about it. Just remember, a normal myocardium will be able to pick up those isotopes. Now, if a myocardium is not getting enough perfusion or blood supply, then that part of the myocardium will have decreased isotope uptake. And then you can think that, well, this part of the heart is not getting enough blood supply. That's why there is decreased thallium uptake. Exactly same like you get it in the echocardiogram. Normal myocardium will have a normal contraction. If there is decreased blood supply to particular myocardium, that will also have decreased wall motion. And if you can have a wall motion decreased or abnormality, you can say that that part of the myocardium is not getting enough blood supply. And that is what we get in this echocardiogram showing regional wall motion abnormalities. Any of these two are positive, that also suggests underlying ischemic heart disease. Now, what if the patient cannot exercise? If a patient cannot exercise, then there is alternative method of stressing the heart. And how we do that? You can give something which will cause similar effect on the heart as if you are running on a treadmill. So you give some adenosine or dipyridamole, and your heart will be pumping or contracting in response to this dipyridamole. And at that time, you will also use some thallium scan. So that's one test that we can do. And that is your chemical stress test. Okay, because you are using chemical to stress the heart. Or sometimes you can give dobutamine to the patient, and at that time you can do an echocardiogram to find out any wall motion abnormalities. So same like before, in this case, patient is not able to exercise, so you are making the heart feeling like patient is doing some exercise. So you are stressing the heart by giving some chemical like dipyridamole. And you can either use the isotope scan or echocardiogram on the top of that. I know that this is a little bit of confusing for you, but sometimes these questions come in exam. So if you have a good basic, it will be so clear for you. Now, exercise tolerance test. This is all the things that we have discussed so far. So you can see there is exercise tolerance, there is exercise thallium, there is exercise echo. And then there is chemical stress. One is dipyridamole thallium, another is echo. Okay, so if a patient is able to exercise, then you just do the exercise tolerance test. That means patient will run on a treadmill and you will find out if there is any ECG changes suggesting ischemia. Now, what if there is baseline ECG abnormality, but patient is able to do exercise? So patient will exercise, but you will use thallium as an isotope, or you will do an exercise echocardiogram. If patient is not able to exercise, then you will do the chemical stress test, which is dipyridamole thallium isotope or dobutamine echo. Is this something which is clear, guys? Great. You guys are really understanding what I'm saying. And this is one of the hardest thing. I know that it goes beyond your imagination sometimes, because most of you have never ever has done this kind of test, right? But that's good that you are understanding. Now, a man with atypical chest pain is found to have normal nuclear isotope uptake in his myocardium at rest. On exercise, there is decreased uptake in the inferior wall. Okay, now see that you have got a patient with a chest pain, you send the patient for an isotope scan, and at rest, there is normal uptake. But when you read it on exercise, there is a decreased uptake in the inferior wall. And 2 hours after exercise, when patient took rest, the uptake of the scan again returned to normal. Now, what it suggests? It suggests that this patient having a stable angina, that means ischemic changes when patient is exercising. Now, if you get a positive finding like this, what is the next step? The next step is to do a coronary angiography. Why? So this patient has reversible ischemia on the stress test, this is exactly the person who needs angiography. Now, if you can do a angiography in this patient, you will be able to see how severe stenosis is there. And if you get severe stenosis, you can put a stent into the patient coronary artery, and this patient will never ever get the myocardial infarction. So you are preventing myocardial infarction just by doing all of these things. So coronary angiography is the best test to detect how severe is your coronary artery disease or coronary artery blockage. Depending on the percentage of blockage or stenosis, the further management will be decided. Some patient will go for angioplasty, which is putting on a stent. If it is very severe and multiple coronary artery is detected, then the next step will be a bypass surgery. Normally, we say that stenosis, which is less than 50%, that is insignificant. But when it becomes more than 70%, that's a significant stenosis. Now, if you look at this chart, you will understand what I'm trying to say. So you've got a patient with a chest pain, with typical ischemic heart disease kind of chest pain. You have done a ECG on rest. If there is any resting ECG abnormalities, if it's no, that means you can do a exercise stress tolerance test. You just need to ask the patient that is this patient able to exercise? If yes, then you send the patient for exercise stress test. Exercise stress test showing ECG changes, you send the patient for coronary angiography. In the angiography, patient got 1 or 2 vessel disease. Use the appropriate management for this patient will be a stent placement or angioplasty. If it's a 3 vessel disease, like all the 3 main vessel has been blocked, that patient will get a CABG or bypass surgery. What if this patient having no resting ECG abnormalities, but patient is unable to exercise? Then you have to do a chemical stress test, which is either helium scan or dobutamine echocardiogram. And if there is positive finding, then again angiography. If there is a resting ECG abnormalities, then you have to go for a stress echocardiogram or nuclear stress test, which is the thallium stress test. Okay, so this is how you think in your head. If you understood what I said in the last 10 to 15 minutes, this chart is everything about the discussion. Very, very important. Now, you will get a lot of questions with this option of Holter monitoring. What is Holter monitor? Remember one thing, Holter monitor is a continuous ambulatory ECG monitor that record the rhythm of your heartbeat. Holter monitoring is mainly done to detect any arrhythmia, especially atrial fibrillation, flutter, any ventricular ectopics, those kind of arrhythmia. You never ever do Holter monitoring to detect ischemia. Okay, so never choose Holter monitor for a patient with a chest pain. Now we are going to move into more interesting thing. So you have got a 48-year-old woman comes to the office with chest pain that has been occurring over the last several weeks. The pain is not reliably related to exertion. She is comfortable. The location is retrosternal. She has no hypertension and ECG is normal. What is the most appropriate next step in management? CKMB, troponin, echocardiogram, ETT, angiogram, CT angiography, cardiac MRI, Holter monitor. What do you think you will do to this patient? So for several weeks, this patient having chest pain. which is not related with exertion. Although you know that this patient most likely has got a gastroesophageal reflux disease, if there was an option of reassure the patient, you can do that, but that option is not here. So what you want to do, you have already done a ECG that is normal. The answer is exercise tolerance test. Okay, why? You don't need to do a cardiac enzyme in this patient because this patient is already having several weeks of chest pain. Echocardiogram is mainly to evaluate valve function. The exercise tolerance test is to evaluate any stable patient with chest pain in which your diagnosis is not clear. Okay, now the important thing, always remember, she is comfortable now. If a patient does not have chest pain at the moment, but she says that she's getting a little bit of chest pain over the several weeks, but at the moment ECG fine, patient is not having any chest pain, only thing that you can do is the exercise tolerance test. And if during exercise there is any ischemic changes there, then only you can think that this patient might have got some cardiac related symptoms. Okay, there is no other need to do anything else apart from an exercise tolerance test in here. But if there is an option of reassurance, that would be the best. We don't need to do exercise tolerance test for this patient, but you don't have that option. In AMC, there will be a lot of time when you will not get the most appropriate option, but you have to choose something. In that case, always think about the best option that you have. Yes, Dr. Shakir. So usually I would not say that this is a ischemic heart disease, but as I say that you don't have any options, you have to choose one. So in that case, the best option to choose out of those is to do a ETT. All good, guys. So now let's move on to the management. It's very, very important and tricky to manage a patient with an acute coronary syndrome. Always remember the first management, which actually has a mortality benefit for a patient with suspected MI, is aspirin. Always, unless it is contraindicated, aspirin is recommended in all patients. So you should always offer aspirin in a patient who is having a possibility of MI. Along with that, sometimes we go for other antiplatelet therapy, like we also give aspirin with clopidogrel or prasugrel in some cases. Now, most of the time, if it's a ST elevated MI, that patient might need immediate coronary PCI, like percutaneous coronary intervention. For those patients, you will not give clopidogrel. That means any patient who will require urgent surgery, we will not give clopidogrel. We will just give aspirin, that's all. Because if you give clopidogrel, that's a blood thinner and patient can end up having a lot of bleeding during the surgery. Now, one by one, we will move into the management of a patient with a suspected MI. The first thing that you need to learn that if you get a patient with a ST elevation, that patient already having a MI. So having a characteristic chest pain, and in the ECG there is ST segment elevation, you don't need troponin to confirm the diagnosis. The most important thing that you need to do is to give aspirin to this patient. You can do troponin, but that's not very important as part of your diagnosis. And you need to call the catheter lab to arrange the percutaneous coronary intervention as soon as possible. Now, the timeline, when a patient enters into the emergency department, you should send that patient to the PCI lab within 90 minutes. Okay, that's the highest amount of wait you can do. Now, there will be a lot of confusion in your head about this time. Okay, so the 90-minute rule is when a patient with a typical cardiac chest pain enters into your emergency department, within 90 minutes, you should send the patient to the catheter lab. And this 90-minute doesn't mean that only a patient who presents to you within 90 minutes of chest pain will get the PCI. What is the timeline for doing PCI in a patient with ST elevated MI? Until 12 hours of having the onset of chest pain. Okay, so 12 hours of onset of chest pain, that's the time duration for doing a PCI or thrombolytic therapy by some thrombolytic drugs. Which one is the best? PCI is the best. But sometimes you might be in a rural country or rural hospital from where sending the patient to a tertiary hospital will take more than 90 minutes. In that case, you don't wait for sending the patient, you just give thrombolytic therapy to that patient in your rural hospital. Now, both thrombolytic drug and PCI, the timeline is until 12 hours of onset of symptom of chest pain. All right, is this clear for everyone, guys? And all this treatment is mainly for ST elevated MI patient. Remember that the thing that I told you, ST elevated MI patient will need thrombolytics. But what if it's a non-ST elevated MI? You don't need to send the patient to the catheter lab, or you don't need to give the patient thrombolytic drug. You can do coronary angiography on this patient, that's fine. And depending on that, you can treat the patient later on, but you don't need to send the patient immediately for a catheter lab or immediately for a thrombolytic drug. For non-ST elevated MI, the treatment will be aspirin, clopidogrel, and also you have to give the heparin. Now let's move on to one by one question and you will understand. A 70-year-old woman comes to the emergency department with crushing substernal chest pain for the last hour. And ECG shows ST segment elevation in V2 to V4. So for the last 1 hour, patient having chest pain, and it's a very elderly patient, there is ST segment elevation also. What is the most appropriate next step in the management of this patient? So you have got all these options. In exam, you will never ever get options like this. There is always 5 options you need to choose from. But let's assume out of all these things, what is your most appropriate next step? Do you want to do a troponin? Do you want to consult cardiology, angioplasty, transfer the patient to ICU, or giving morphine? Always remember, this patient will need aspirin. Many of you know about MONA therapy of acute MI. MONA is for morphine, oxygen, nitroglycerin, and aspirin. Now, just because morphine is at the first, it doesn't mean you have to give morphine at the first. The first thing that you give to this patient is aspirin. Yes, obviously, we might need to give morphine to this patient if chest pain is severe. We might need to give oxygen if saturation is less than 94. And also, if chest pain is not getting better, we might also give nitroglycerin. But none of this is having a mortality benefit like aspirin. Okay, so aspirin will be your next step. So that's your answer, D. Now let's say the exact same question, but you have given aspirin to the patient. What is your most appropriate next step? So CKMB, oxygen, nitroglycerin, morphine, thrombolytic, metoprolol, atorvastatin, angioplasty, troponin, lisinopril. Once you have given aspirin, your next step is always sending the patient for angioplasty, which is the PCI. I know that this becomes so confusing because in most of the time, we would choose morphine, oxygen, troponin, all of it. But when a questions come in the exam in terms of acute MI with the ST elevation, your choice will be first give aspirin, and the next most appropriate thing is to call the catheter lab to send the patient for angioplasty. So angioplasty is associated with the greatest mortality benefit of all the steps listed in the question. All of the answers are partially correct in that all of them should be done for the patient. Again, morphine, oxygen, nitrate should be given to the patient immediately, but they do not clearly lower the mortality. Okay. Now, this patient started to have chest pain for the last 1 hour. Even if you do a troponin, it might not be elevated, right? So it will not give you any information or anything. This patient, you will not wait for 4 hours when you get a ST segment elevation. Okay. Now, let's say a man comes to the emergency department with a chest pain for the last hour that is crushing in quality, does not change with respiration or position. ECG shows ST segment depression. Now, when ST segment is depressed, it's not a ST elevated MI. Remember that. Aspirin has been given. So what could be the possibility in here? Now, the important thing is that it, like this ST segment depression, it can suggest unstable angina. It can suggest non-ST elevated MI also. If there is an option of doing troponin, we would do that just to confirm what we are dealing with. But whatever is the diagnosis, this patient will need low molecular weight heparin after aspirin. See that heparin will prevent a clot from forming in the coronary arteries. It does not dissolve clot that is already formed. When a patient has acute coronary syndrome and there is no ST segment elevation, there is no benefit of thrombolytic therapy. Okay. And you can have a look at what is the difference of treatment in various kind of acute coronary syndrome. Aspirin we give to all kind of ischemic heart disease, whatever it is. Beta blocker is a part of management, so we also give it to them. Nitrate for everyone. Heparin is only for ST elevated, non-ST elevated MI or unstable angina patient. Thrombolytics only for ST elevated MI. Calcium channel blocker for no one, warfarin for no one, antiplatelet drug for acute coronary syndrome we can give like aspirin, clopidogrel, that's for unstable angina or ST elevated MI. Okay. So the most important thing to understand is that according to the symptom, according to the ECG finding, you have to choose your option correctly. If it's a non-ST elevated MI, aspirin followed by heparin. Same with unstable angina. If it's a ST elevated MI, aspirin followed by PCI. Now, let's say you have given heparin in a non-ST elevated patient. Any non-ST elevated MI patient should have a coronary angiography done within 48 hours. Because this patient can end up having a full-blown ST elevated MI unless you treat properly. You're giving heparin that will prevent formation of any further clot. But you will need to revascularize that patient. So send the patient for coronary angiography, and depending on the result of it, further management will be either angioplasty or bypass grafting. So these are all some of the explanation. You can give it a read by yourself. See this one, patient with a ST elevated MI who present within 12 hours of the onset of ischemic symptom should have a reperfusion strategy. The reperfusion can be by fibrinolytic therapy like alteplase, retiplase, or with PCI. Patient presenting with non-ST elevated MI will not benefit from thrombolytics. No, aspirin can be given in a stable angina also. Aspirin is better for any kind of angina. Now, some of the typical changes in a ST elevated MI patient. Sometimes they ask you, like, what is the immediate ECG change? Immediately, at the onset of chest pain, you will get hyperacute T wave, which is tall peaked T wave. And after tall peak T wave, then patient will get ST segment elevation. And then 1 to several days later, patient will develop pathological Q wave. And 6 to 24 hours, patient will develop T wave inversion. Now, I know that it might be a little bit of confusing for you because I haven't shown you the ECG. In the ECG class, you will know about this waves segment and everything. But remember this table, the typical ECG changes in a ST elevated MI patient. Now, the important thing to understand that when you are going to do an emergency reperfusion therapy, you have two choices, right? You have a PCI and you have fibrinolytic. As you can see here, PCI is the best available treatment if you can provide it promptly. And PCI is usually done in a patient with ST elevated MI presenting within 12 hours. And in general, a time delay of 90 minutes from the first medical encounter to PCI is the maximum desirable. Now, do not confuse these 12 hours and 90 minutes, guys. In JM, there is a confusing line written like this. This 90 minutes, as I said, it's a when first time patient present to the ED with a typical chest pain like this, and you send the patient to the PCI lab, the delay should not be more than 90 minutes. Okay. Where you can't do PCI or it is not available, then you go for thrombolytic therapy, which is with tissue plasminogen activator or streptokinase. And also the greatest benefit is in patient with ST elevation who have symptoms for less than 12 hours. So any reperfusion treatment should be within 12 hours of onset of symptom. After 12 hours, doing a reperfusion therapy does not change the prognosis of the patient. You can do it, but it will not change the prognosis. Now, some patient might have contraindication to thrombolytic treatment. So you need to know about that, like someone having a bleeding disorder, someone having active bleeding at the moment, significant head injury within the last 3 months, suspected aortic dissection, previous history of intracranial bleeding, or ischemic stroke within the last 3 months. These patients are contraindicated to get the thrombolytic therapy. Okay, for them, PCI is the best treatment. Now, if the patient present late, like 12 hours after symptom onset, reperfusion therapy with either PCI or fibrinolysis is not routinely recommended in patients who are asymptomatic and hemodynamically stable and present 12 hours after onset of symptom. For this patient, yes, you will do coronary angiogram, and depending on that, you can do a coronary bypass or angioplasty later on. Now, what could be the complication of a patient with myocardial infarction? Patient with myocardial infarction can have a lot of complication or even sometimes life-threatening one. Sometimes question asked, what is the most common cause of sudden cardiac death after MI? Anyone? Yes, ventricular fibrillation. So VT or ventricular fibrillation is the most common cause of sudden cardiac death after having a MI. Another thing, a patient with MI sometimes can develop features of pericarditis, and that has a specific name known as Dressler syndrome. So if a patient with a MI recently been treated having chest pain typical of pericarditis, think about Dressler syndrome. And the treatment is same with pericarditis, like aspirin, NSAID, or steroid. Now, remember the Prince metal angina that we talked about it. So all the MI related things are done. Okay. Do you guys have any question related with myocardial infarction or stable or unstable angina? For stable angina, aspirin will be your treatment. And with aspirin, you will also give nitroglycerin. And also we add beta blocker ACE inhibitor as a part of treatment. Now, for Prince metal angina or variant angina, what is actually variant or Prince metal angina? This patient will have symptoms of angina or typical chest pain of ischemic heart disease. Why? Because the coronary artery is having a spasm in this case. And sometimes you can get ST segment elevation on the ECG. If you get ST segment elevation, you should always treat the patient just like a ST segment elevated AMI. When you send the patient to the catheter lab, in the angiogram, they will find out no obstruction. And then the diagnosis will be Prince metal angina or variant angina. Okay. Now, as opposed to the typical angina, Prince metal angina usually occurs during period of rest, most often at night and early morning. So that's one of the things that will help you to diagnose this case. If you do exercise tolerance test, that will be normal. If you do a coronary angiogram, that will be also normal. But how you can confirm diagnosis? You can do a coronary artery spasm provocation test by giving argonovin. Argonovin is supposed to cause coronary artery spasm. And if you give argonovin and then see there is chest pain and ST elevation in the ECG, that can confirm your diagnosis. Now, the treatment is not similar like your angina or ischemic heart disease. In this case, the problem is coronary vessel spasm. So if you can give something which will dilate the artery, that will be the treatment. So which causes coronary vasodilation? Calcium channel blocker or nitrate. So this will be your treatment in this patient. So during an acute episode of pain and ST segment elevation, you can't tell who has pharyngeal angina or who has acute ST elevated MI. Therefore, you must initially treat everyone with chest pain and ST elevation as if they were having an acute MI. You can only confirm pharyngeal after doing a coronary angiography. That's important. Yes, Dr. Aisha, the difference between the 90 minute and 12 hours, just forget the 90-minute thing. It will never come in the exam. The thing about 90-minute is when a patient with a typical chest pain with ST segment elevation comes into your hospital, your job is to send the patient to the catheter lab. Now, it needs time to arrange this, right? That time of arranging or sending the patient to the catheter lab should not be more than 90 minutes. It has nothing to do with the onset of chest pain. Okay, if the patient comes to you within 12 hours of chest pain and having ST elevated MI, you should send the patient to the PCI or catheter lab, right? Now, that time between the first medical contact of the patient and sending to the catheter lab cannot be more than 90 minutes. So it's actually like you have to do it as soon as possible. That's the thing. Yeah, Dr. Shakir, similar to the Takotsubo syndrome, right? Any questions so far, guys? You guys are understanding what I'm saying? All good. Now let's go on to aortic dissection. Another important topic in terms of chest pain. The pain is usually sudden, severe, and midline or retroesternal chest pain, which is tearing or ripping sensation. The pain will be retroesternal and it will radiate to the back and as if it's in between the scapula. It can also radiate to your abdomen, flank, and the lower legs. The important diagnostic feature is the inequity in the pulse. So you will find out that there is radio-radial delay. There is delay in between carotid, radial, and femoral pulses. So if you try to palpate the two radial artery in the two arm, you will find out there is an inequality in the pulses. So inequality in the pulses, inequality in the systolic blood pressure in both arms, this suggests aortic dissection. Okay. Now, in case of aortic dissection, you will obviously initially you will do a ECG because patient having chest pain, and ECG will be normal in this case. And what is your most appropriate investigation? That's the question that comes in exam. According to your JM, they have written CT angiogram is important, but the definitive diagnosis best achieved by transesophageal echocardiography. Now, in between CT angiogram and transesophageal echocardiography, if you have to choose, you should choose the transesophageal echocardiogram. If transesophageal echocardiogram is not in the option, then you can choose CT angiogram. Now, aortic dissection management comes in exam and is very important. To understand the aortic dissection management, you need to first understand the type of aortic dissection. Now, if we draw a picture, like let's say this is an imaginary heart, and that's your aorta, right? And aorta has got three major subtypes. One is brachiocephalic artery, left carotid artery, and left subclavian artery, right? So if the dissection occurs proximal to the left subclavian artery, that means anything in here, especially in the ascending aorta. So proximal to the left subclavian artery, any dissection is known as type A aortic dissection. And distal to the left subclavian artery, any dissection, especially in the descending aorta, that's your type B aortic dissection. Now, there is importance of knowing it because management is totally different and prognosis is also different based on these two types. Because type A is very close to the heart, the management is very complicated and chances of survival is also low. For patient with type A aortic dissection, the main management is emergency surgery, okay, as soon as possible. But for type B, the management is first to control the blood pressure because these patients usually get a very severely high blood pressure, like more than 200. So the first thing is conservative management in type B. So how you control blood pressure in this patient? The first line treatment is beta blocker. You give IV or especially IV labetalol will be your first line of choice. So you start with beta blocker because beta blocker will not cause sudden drop of blood pressure. Once you give IV labetalol or beta blocker, still blood pressure is high, then you have to give IV nitroprusside. Okay, don't choose IV nitroprusside as the first line agent. Always choose beta blocker as the first line agent. All right, that comes in exam in a lot of questions. So now you know about it. Now, pulmonary embolism is another chest pain, but we don't discuss pulmonary embolism in cardiology. We have an extensive discussion in respiratory system. So let's not discuss about pulmonary embolism. And if you guys want to read a little bit more about these chest pain related things, especially aortic dissection, you can go through this link of Med Bullets. Let me website so that you understand what I was talking about. See that this is Med Bullet, very good for they usually give you a question first so that you understand what they're talking about. And then they discuss about the cases, symptoms, signs, investigations, everything very concisely. So give it a read if you want to know the things in a very shortest possible time. All right, so that's actually our tonight's session. Tonight's session was mainly on chest pain. Cardiology is not only chest pain. Remember one thing, guys. There is a lot of things to discuss, which we are going to discuss in the next class. Okay. Do you guys have any question on tonight's session? All right. So I guess that you guys understood tonight's session. One of the important thing for going into a course is to understand how they take their courses. And now you guys will understand like how each of the classes are designed for your best understanding. The first class, I always try not to scare you a lot. I try to keep it short so that you guys does not get overwhelmed. But the next class, now you know about cardiology a little bit. Next class will be fast. Okay. And we are going to discuss other things like hypertension and some other stuffs related with cardiology. Yes, Dr. Chris, you get the lecture notes once you are a candidate of our course. And I know that many of you knows our course details and everything, but still, just because this is a free session that we are taking, some of you might be new, you may not even know what's this course all about. So for you, I will again show you the video that I have shown in the first class about the course detail. If you have any questions about the course, feel free to ask us. Okay, we are more than happy to answer any of your questions. Just a second, I'm going to open the video. So this is actually a video on our course. If you have any questions, even after watching the video, let me know and I will answer it. All right. So thank you guys for watching that. I hope that it clears anything that you want to know about the course. I don't understand your question, Dr. Chris. Are the notes same as lectures? Yeah. Now, during lecture, obviously, I just don't like read the things that is in front of me. I always try to add things which I know from my experience, from my knowledge. But yes, most of the things that we discuss is in the note. All good. So we'll again meet in the next class. If you guys have any question, feel free to ask anytime. And again, the course admission is open now, and try to just contact us if you want to enroll yourself, because this 2 weeks time you can invest this 2 weeks time to get into the course, get into the subscription of software and everything. It takes a little bit of time. So if you want to start the process, if you like our style, like the course already, you can always start your entry into the course right now. Okay. So thanks everyone. We'll see you in the next class. Good night. Bye.